afternoon, and thank you, Dr. Grant, and the committee for inviting me. It's kind of an unusual invitation, since it's not a group with which I'd been at all familiar. In fact, I came yesterday to hear the talk on what is Chiari, because I see the name associated with POTS, but I had very little understanding. I'm very bad with these mics. I'm like the Singing in the Rain character who always talks away from the mic. The other thing is that it's commonly said that an expert is somebody from out of town. Since I'm not really from out of town, I therefore do not claim to be an expert. I'd like to give you some information and background about POTS. And the name, again, one thing I emphasize is that it's a description. It's by no means a diagnosis. Let's see how we get down here. Okay. So with any medical condition, you're really looking at three aspects. What is it? Why is it there? And what can be done about it? So I'd like to address these three areas. There's an Indian fable about blind men who encounter an elephant. To the person who has the trunk, he describes the creature as looking like a snake. To the person who has the tusk, it seems as if it's a spear. To the person feeling the ear, it's a fan. To the person feeling a leg, it feels like a tree. To the person who's feeling the side of the elephant, it feels like a very large wall. And to the person having the tail, it seems like a rope. And just as none of these give you the full comparison of or assessment of what an elephant is, similarly, a fast heart rate does not give the full description of what POTS really is. One of the things that's interesting is that the NIH has gone from a definition of POTS to a description of POTS, reflecting that the more we know, the less we understand. That initially it was an increase in heart rate over 30 beats a minute when the patient stands and an elevated norepinephrine level. They did include many orthostatic symptoms. Now it describes POTS as one of a group of disorders with orthostatic intolerance. And again, the heart rate criterion are there, but it also mentions that it can occur more often in women and may often be brought on by events. This is the autonomic nervous system. It's a balance between the sympathetic system, adrenaline, and the ability to increase heart rate, and the parasympathetic, which is the balance. One thing I discuss with patients is that there are clearly many areas within this, it doesn't show up, within the autonomic system where things can go wrong. The initial tissue might generate the wrong signal that may be translated inappropriately through ganglia. The brain is obviously the coordinating center, and the wrong signal may be sent out, scrambled at the plexus, or the tissue itself may not respond appropriately to a signal. So autonomic dysfunction is very difficult to assess, and because the autonomic nervous system is designed to be dynamic, can be very difficult to evaluate. This was a study from the Mayo Clinic looking at patients with POTS, that 40% of them had a history of orthostatic intolerance. About 12% of them, it actually ran in the families. The onset was anywhere from less than a month, but more commonly, it tends to be a more chronic condition, and certainly by the time they go to a major center like the Mayo Clinic. Again, often the etiology is unknown, and you can see that unspecified is, let's see, okay. So that the orthostatic symptoms are described are pretty understandable. They're lightheaded or dizziness, syncope, near syncope, but also palpitations, an abnormal feeling of the heart rate, shortness of breath, as Nancy mentioned, chest pain can occur. And the symptoms are worsened by heat, exercise, occasionally by meals, and not infrequently in women by menses. But in addition to the symptoms related to a change in posture, there's also others, particularly GI symptoms, bloating, nausea, abdominal pain, constipation and diarrhea, as well as other systemic symptoms such as fatigue and sleep disturbance. This is a, sorry, they're loaded here. I have a patient who faints who is an artist. I can tell what her blood pressure or cerebral perfusion is like, is when she's close to fainting, the pattern becomes more swirly, the palette is blues and grays, and as she gets close to fainting, even that color palette goes. And this gives an idea of how symptomatic people can be if they're close to losing consciousness. When there was a survey by the Mayo Clinic group looking at the quality of life in people with POTS, they found that there were major limitations in their quality of life. And what they found was that emotional functioning and mental health functioning were actually comparable to normals, which is the left side. But in others in whom the POTS patients, which is the black bar, that the physical status, the physical functioning, pain, and general health, vitality, are all comparable to patients who have more chronic illness, congestive heart failure or COPD, than they are to normally young, healthy people. So what is POTS? Why is it there? It's an interaction, as I mentioned, between the heart, the vascular system, the kidneys, the brain, and the nerve terminals. So this is a study done at the Vanderbilt group, where they looked at orthostatic changes in heart rate, which is the top panel, and in norepinephrine levels, norepinephrine and epinephrine levels when standing. You can see that the POTS patients, which are the open bars, that the heart rate dramatically shoots up. The blood pressure does not particularly change, but the levels of norepinephrine and epinephrine, catecholamines or adrenaline products, are markedly increased. This is data from Julian Stewart in New York, who looked at venous pooling. You can see that he's using transducers on the calves of patients during tilts. On the left is a patient with POTS, on the right is normal. And it shows the increase in leg diameter that occurs in patients when they're on the tilt table test. The venous capacitance, so the longer they stand, the more blood is pooling in the legs. And obviously, if it's pooling in the venous system, in the gut or in the legs, it's not available for the vascular system. And this is just reflecting that decrease in venous capacitance. As mentioned, they also tend to have a reduced blood volume. In these figures on the bottom, the red is POTS and the yellow is normal, so that they have a combination of both increased venous capacitance and a higher risk of venous pooling, but also an absolute total lower blood volume. When studies have been done looking at renin and aldosterone, which help to increase vasoconstriction, these also are impaired in POTS patients. This is also looking at the stroke volume. So obviously, if there's a lower blood volume, there's going to be a lower stroke volume. And you can see that with tilt, there's even a greater difference in the stroke volume. The lower stroke volume also enhances peripheral vascular resistance because the body's trying to maintain blood pressure, and the resistance is actually, in the arteries, is actually higher, but the blood volume is low. There's a study from UT Southwestern suggesting that POTS patients may have a smaller heart size, But again, is that a function of exercising, or is it part of a bigger global syndrome? So again, why is POTS there? It is not a single etiology. It's certainly multifactorial, very different in different patients, and it may be a combination of factors in individuals. It can be neuropathic, again, the low blood volume, the excessive sympathetic discharge, small heart size, or the mast cell conditions. This is just a list of associated syndromes that have been compiled by the Dysautonomia Information Network. So it ranges, it's in alphabetical order. So Chiari malformation, the Ehlers-Danlos deficiency, and Syringomyelia certainly fit into other syndromes that have been identified. There's not a lot of data, though, at least that's published, about what those interactions are. These are a couple of studies that actually looked at the hypermobility. One was actually published in an orthopedic journal, where looking at those patients who had hyperflexibility, over a third, almost a third, reported tachycardia or chest pain. Another group later also found that those who had the joint hypermobility, probably a Ehlers-Danlos variant, had not only syncope and presyncope, but impaired palpitations, impaired concentration, heat intolerance, and hyperventilation. This is, again, data from that study shows that at 3 minutes, the patients with hypermobility had a much greater decrease in blood pressure, much higher increase in heart rate, and their standing tolerance was actually significantly different by almost 5 minutes. Autonomic testing in those patients did demonstrate the hypermobility patients also had a mild dysautonomia and hypersensitivity to both alpha-1 and beta receptors. So to go on, the group at Johns Hopkins has been very active in the area of Ehlers-Danlos, which is why the Ehlers-Danlos meetings are held in July in Baltimore, which is not the best location for people who are heat sensitive. But in 1999, they indicated the high incidence of orthostatic intolerance in those patients who do have Ehlers-Danlos. And that it's something that should be examined in people who have chronic fatigue syndrome or orthostatic syndrome, orthostatic intolerance syndromes. 5 years later, the same group with Howard Levy as the first author published an update, and this was also updated in 2010, saying that neurally mediated hypotension, or POTS, should be a minor diagnostic criterion that are supportive of, but not sufficient to diagnose the EDS hypermobility type. Let's see. Okay. So again, we're looking for a missing link. What is the link between joint hypermobility and autonomic dysfunction? As you heard, there certainly is an overlap of physiology in those people who have a Chiari malformation. Ian Carroll yesterday presented a very lovely study about the cerebral spinal fluid leaks. And recent MRI studies suggest that there may be co-location of a loci that's active in patients who have the joint hypermobility and who have autonomic dysfunction. Again, this is largely in the caudate nucleus. So there is also a paper out last year where they looked at antibodies to receptors in the adrenergic system, both the alpha and beta receptor, so that they have elevated antibodies against the alpha receptors so that you get more tachycardia, more vasoconstriction, as well as increase in beta receptors, which facilitates the tachycardia. And I won't go through this whole paradigm, but basically what they show is that with POTS, they get, when they're standing, there's pooling of blood, there's impaired vasoconstriction. When there's impaired impaired vasoconstriction, there's more blood pressure drop, and an exaggerated response in heart rate, so that these antibodies may help to explain some of that physiology. Now, in terms of what to do about it, again, I hope I've illustrated that we really are not clear what exactly is causing POTS. But this is the French artist Henri Lautrec. And the question is it better to, what is the best way to augment venous return? Is it with compression stockings? Or is it with splanchnic compression? And actually, this is Oprah wins here because there's data from Philip Lowe, who is at the Mayo Clinic, where 2/3 of the blood flow when anyone stands goes to the gut, even more to the legs. So that a way to help combat that is by using abdominal binders, increasing abdominal pressure. Physical therapists such as Nancy can get them to improve the muscle tone in the abdomen, help to increase the venous return. This is actually a study where on the left, they took healthy, normal young people, put them on a tilt table and tested them, and showed that they actually did not all finish the test, and some with no history of fainting actually did faint. But after chugging a bottle of water, that markedly improved their time of standing. So that there's something about acute volume expansion, even chugging a bottle of water, which seems to alleviate symptoms and improve blood pressure even more than just taking that blood pressure. So in terms of treatment strategies for POTS, the focus remains on symptom management. So again, with reducing venous pooling by avoiding standing for long periods, hot showers, hot tubs, the abdominal binder. One thing that you find in people who do have the hypermobility is often they'll report they never have felt well in hot tubs, or always felt more tired or more fatigued if they were in hot weather. That exercise may also improve not only the muscle component of venous return, but the group at UT Southwestern suggests that it may also improve some of the neurohormonal functioning. Again, the exercise data comes in from a group that specifically excluded the Ehlers-Danlos patients from the study. And again, midodrine is both arterial constriction as well as venous constriction. Other things that can be done are to increase blood volume. Florinef aids in salt retention. Patients are typically advised to increase markedly their salt and water intake. I actually have finally found a kidney specialist who will even talk to me about low blood pressure, because the vast majority of kidney disease results in high blood pressure. And if you ask them, well, why do you have to tell people to eat more salt and drink more water? I mean, isn't that what kidneys are supposed to do? They look at me like I'm crazy. So I actually have found a nephrologist who's interested in that balance and in people who tend to have a low blood pressure. People will often require IV fluids, particularly if they've been in a situation where they've not been able to take oral intake, the weather's excessively hot, and often an IV fluid will make them feel better. It can also be frustrating going into an emergency room, they put on a gurney, the IV started, and by the time they're seen by a provider, they feel so much better because they've already gotten a liter or two of fluid. Again, in terms of medications, they are looked at, clonidine can help reduce sympathetic outflow, particularly with those patients who have the hyperadrenergic. Beta blockers might be useful. Again, there's no real consensus as to which beta blocker is best. So even if one is not tolerated, others may be tolerated. One of the things that's important with patients is because they tend to run low blood pressures, that they don't tolerate being started on standard doses of beta blockers, because if a component of the fast heart rate is compensating for a low blood pressure, you don't want to completely wipe out the heart rate. The people complaining of mental fog, they may need the modafinil, Provigil, Nuvigil. Some respond to ADHD treatments. The pyridostigmine can be useful, particularly in some people who have the GI symptoms, because it improves nerve transmission. Midodrine and decongestants are also vasoconstriction. Again, there's an issue in terms of the CNS regulation, whether SSRIs may be useful for some patients, not because they are anxious or depressed, but because the brain is the coordinating center of the autonomic system, and using the SSRIs may help facilitate that coordination. So, any treatment strategies that are based on etiology, clearly that's the goal of medicine, is to understand what's going on and to direct your therapies at the underlying physiology. But unfortunately, right now, there are no proven strategies. Dr. Carroll, again, has started to look at the blood patches for CSF leaks. There are, in the chronic fatigue community, they have been testing for infectious or viral etiologies and are looking at antiviral therapy, combining the overlap between the chronic fatigue and POTS. And again, the whole question of, are there antibodies to the adrenergic system that might be targeted? Again, many good ideas, nothing is proven. So to end and say, this is the same patient whom I've seen, and when her blood pressure is better and she has better perfusion, her palate is much brighter and the shape's much more distinct, and one can only hope for brighter days for our patients. Thank you. And these are just some of the experts whose work I've quoted in here, be the true experts in the field.
Thanks so much. That was enlightening for me as well. One question while Dr. Zhang is getting up for a talk? Okay. It's a tough disorder. I think you're really comprehensive going through that. That was great. Maybe in the panel we can address more in a few minutes. So thanks so much for joining us.
Figure out how to get out. Help.